Okay, well, maybe I'll get started with the introductions and other people may join us as we get going. So welcome, everyone. My name's Fiona Lewis, and I'm the Patient Support Liaison for AMAC. I'm pleased to welcome you to this webinar. AMAC is a leading funder of research into bone marrow failure diseases in Canada and supports patients and caregivers across the country who are living with aplastic anemia, myelodysplastic syndrome, and PNH. Last year, we were pleased to offer a number of regional in-person patient education meetings, and we're going to continue with these in 2024. We also continue to offer monthly Zoom patient support meetings. So please check out our website to register for any of those meetings and to access our other resources. Your line will be muted during today's presentation, but you can type any questions you have into the Q&A feature, which you should be able to see at the bottom of your screen. And if there's time, I'll also unmute the lines to allow for more questions. Please note that today's webinar will be recorded and posted on our website next week. So I'm pleased to introduce Dr. Pasic to present today's webinar regarding BMT 101, the basics of allogeneic hematopoietic cell transplantation. Dr. Pasic is a physician with the Hans Messner Allogeneic Transplant Program at the Princess Margaret Cancer Center. He's also an assistant professor with the Department of Medicine at the University of Toronto. So welcome, Dr. Pasic.
Can you hear me?
We can, yes, thanks.
Excellent. So good evening, everybody. So thank you for that kind introduction. As you pointed out, I'm a staff physician in Hans Messner Allogeneic Transplant Program at Princess Margaret Hospital. I'm also a clinician investigator with the Department of Medicine at the University of Toronto. And I want to thank the organizers for giving me the opportunity to give this session today. And in this session, titled BMT 101, what I'll try to do is give you some general overview of allogeneic hematopoietic stem cell transplantation. So here are my disclosures. I have received speaking honoraria and participated in the advisory board of 2 pharmaceutical companies, Jazz and Medexus Pharmaceuticals. But none of the material that I'm presenting to you today has anything to do with these relations. These are the learning objectives for our session today. At the end of the session today, the learner should become familiar with the basic and major milestones in the history of stem cell transplant, the discovery and the roles of the HLA system, basic principles of HCT, including determination of indication, eligibility, donor selection, and choosing the most appropriate conditioning regimen and the form of GVHD prophylaxis. Common complications of stem cell transplant with a special emphasis on GVHD, and issues related to long-term survival post-stem cell transplant. So let's start by reviewing the milestones in the history of stem cell transplant. So this study summarizes the last 70 years, this slide summarizes the last 70 years of HCT, and I do want to highlight a few points. It was actually the nuclear bombing of Hiroshima and Nagasaki in World War II that effectively marked the birth of this field. The first allogeneic stem cell transplants was performed in 1957, which was actually years before the discovery of the HLA system, the system that our body uses to recognize its own from the foreign. Discovery of 2 immunosuppressive drugs, which formed the backbone of immunosuppressive therapy for decades, anti-metabolite methotrexate in 1948, and calcineurin inhibitor cyclosporin in 1972. And the combination of the 2 drugs was established as a standard of care for graft-versus-host disease prophylaxis in the 80s. The first transplant from an unrelated donor was performed in the 80s. The description of reduced intensity conditioning in the 90s, which allowed transplantation of less fit individuals. Discovery of anti-T cell antibodies such as antithymocyte globulin or ATG, which are now used in some parts of the world, including Canada, for prevention of graft-versus-host disease, as well as the introduction of post-transplant cyclophosphamide in 2000s, which allowed the transplantation using half-matched of haploidentical donors. This is a lot, but I will get through each of these points over the next 20 minutes or so. So as I mentioned, the history of allogeneic stem cell transplant dates back to one of the sort of most tragic events in human history, which was the nuclear bombing of Hiroshima and Nagasaki in 1945. It quickly became obvious that many individuals who were affected and survived started dying off within weeks of acute radiation exposure. So of all the energy released by the 1945 A-bomb, about 50% was released as a physical force, which caused the blast. Another 35% as a heat wave, while about 15% of the energy was released as radiation, consisting of both gamma and neutron waves, which caused significant radiation injury to an area with a radius of approximately 2 kilometers away from the hypocenter. As the bomb was dropped in a heavily populated area, it had significant repercussions on the involved populations. So on the left is a graph showing the amount of radiation victims of A-bomb received as a function of their distance from the epicenter, which is usually called hypocenter. So all the individuals within the 0.5 kilometer radius from the hypocenter received 10 sieverts, which is a dose enough to kill a human within several weeks. Moving out, the radiation dose decreased in an exponential fashion with a quick fallout from what started as a lethal dose towards a dose equivalent to a single chest X-ray, which was at about some 4 kilometers away from the epicenter of the bomb. Of the individuals who did not die from the blast or the heat, many ended up succumbing to acute radiation sickness and eventually died of aplastic anemia and bone marrow failure and its subsequent consequences. What we learned from this unfortunate event was that the bone marrow was highly sensitive to radiation, that bone marrow represented the origin of hematopoiesis because radiation of the marrow caused significant cytopenias or low counts in these patients and these individuals, and that radiation represented a potential cure for bone marrow disorders, including blood cancers and bone marrow failure syndromes. In their landmark paper that was published in New England Journal of Medicine in 1957, the group led by the late Donald Thomas showed that intravenous infusion of bone marrow is technically feasible in patients receiving radiation and/or chemotherapy. The group touched on several important concepts, and this is the group that published the first stem cell transplant in the world. That there were no life-threatening and catastrophic events in the recipient after the infusion of the bone marrow grafts, so that was important. They showed that the prolonged engraftment, or take, as they referred to it, was only possible in patients who received enough cytotoxic therapy to cause an aplastic state. And by aplastic state, I mean a state where their marrow is empty. It seemed that the individuals who were not rendered aplastic or empty marrowed, the take was only temporary, suggesting that there was something in the recipient that was fighting off the graft. And we later learned it was the immune system of the recipient. They defined a minimal dose of bone marrow nucleated cells needed for a successful engraftment, which is the size of the seed you have to put in, which was sometimes some 4 times 10 to the 9, between 4 times 10 to the 9 and 40 times 10 to the 9, which is actually surprisingly close to the figures considered and accurate in a modern setting. So it's amazing that these people in 1950s calculated fairly accurately how many cells you needed to put in to get a successful engraftment. Donald Thomas, the man in this picture, won a Nobel Prize for this work in 1990s. It was clear from early on that there was more to stem cell transplant than just infusion of donors' hematopoietic progenitors. The process involved significant risk of complications that were at the time very poorly understood. Shown in this photo is a Dutch scientist, Van Beckham, who showed that a lethal dose of radiation caused death in mice. That death from radiation could be prevented by infusion of what they called isolagus, or now autologous bone marrow cells. So that would be stem cells from yourself. But the mice who received radiation and allogeneic stem cells, meaning stem cells from another mice, did not die of radiation, but they died of something else. They died of something that they called secondary syndrome, which happened weeks later, and that's known as graft-versus-host disease today. And it wasn't actually until the discovery of the HLA system that the physiology or the mechanism of graft-versus-host disease was fully understood. Human leukocyte antigens belong to the major histocompatibility complex, an ancient component of the immune system, whose function it is to present antigens to cytotoxic T lymphocytes. Presented antigens are typically proteins in nature. They're processed by cellular machinery into short molecules, which then MHC molecules expose on the surface of the expressed cells to the surveilling lymphocytes. So these surveilling lymphocytes will then notice these proteins are exposed on the cellular surface, and it will lead to their activation and subsequent activation and immune surveillance or immune activation. Transplant-relevant HLA genes belong to the MHC genes located on the short arm of chromosome 6 in the humans and belong to two classes. MHC class 1 genes are HLA A, B, and C and are expressed ubiquitously, meaning on all different cell types. MHC class 2 genes are HLA DR, DQ, and DP, and they have a more restricted pattern of expression belonging generally to antigen-presenting cells, and these include B cells, macrophages, dendritic cells. HLA focus was discovered, or locus, pardon me, was discovered by 3 scientists in this picture who won a Nobel Prize for the discovery in the 1980s. HLA genes are inherited in a Mendelian fashion, meaning that all individuals have 2 copies of each of the gene, one inherited from each parent. All individuals have equal chance of passing their paternal and maternal alleles to their offspring at each of these loci. And we'll talk about how this affects our matching later. There are now thousands and thousands of alleles of each of the major HLA loci, accounting for thousands and thousands of different versions of the HLA proteins. And it's the combinations of these proteins that create thousands of variations in the population. And that's why finding a donor can be challenging, because we're all very different at these specific sites, although the rest of our genome is actually very similar between each other. The next milestone in the timeline of stem cell transplant was the discovery of methotrexate, which was a drug to be found to be very effective in prevention of secondary disease, or graft-versus-host disease, as we call it nowadays. 2 names that stand out when it comes to discovery of methotrexate. So Dr. Subbarao was an Indian-American biochemist who discovered a drug called aminopterin, which was a derivative of folic acid and that effectively blocked folic acid. And then a physician called Sidney Farber, after whom the famous Dana-Farber Cancer Institute is now named, who discovered that folic acid accelerates leukemia growth in children. He showed that the blockade of folic acid using aminopterin resulted in temporary remission. And it quickly became apparent that aminopterin and its cousin methotrexate have potent anti-neoplastic and immunosuppressive activities, providing the basis for the use of methotrexate in allogeneic stem cell transplantation. Moving forward, the next discovery critical for our understanding of stem cell transplant was the recognition that T cells, part of our immune system, are mediators of rejection and graft-versus-host disease. It was an early discovery by a scientist called Jeffrey Miller that mice whose thymus was removed, the thymus is a gland that sits around the heart, that they are immunocompromised, that led to the discovery of the T cells. So what Dr. Miller did is he grafted skin of one mouse to another mouse. And it showed that mice receiving skin grafts from other animals showed rapid loss of the skin graft due to an acute rejection of the skin graft by their own immune system. They were getting a graft from another animal. Their immune system would attack the graft and kill the graft. Mice that underwent thymectomy, meaning removal of the thymus, who received skin grafts from other animals, they similarly lost their skin grafts. So removing the thymus was not enough to eliminate the rejection. However, those mice that were thymectomized, meaning that had their thymus removed and received radiation, actually showed rapid acceptance of the skin graft, showing there was the elimination of the recipient's immune system from both in the circulating component in the blood and from the thymus that was enough to render the recipient immunocompromised enough to receive skin graft from another animal. Discovery of cyclosporin was another landmark in the trajectory of stem cell transplant development. It was in 1971 by Jan Borel, who began a new era in immunopharmacology. It was the first immunosuppressive drug that allowed selective suppression of T cells without significant toxicity to the patient. Cyclosporin was isolated as an antibiotic from a fungus. It was first investigated as an antifungal antibiotic, but the spectrum was too narrow, meaning that it only affected a very small number of fungi. And it was during those experiments in 1970s that they discovered immunosuppressive properties of cyclosporin. And why did I bring up cyclosporin and methotrexate? Well, because the combination of the two represents the golden standards to date for GVHD prophylaxis or prevention of GVHD. The initial work on this comes from, again, a familiar face, Dr. Don Thomas, who showed in 1984 that cyclosporin and methotrexate provided the effective way of controlling GVHD in dogs who received transplants from haploidentical littermates. And shortly thereafter, this combination was used in human trials. And this is a figure from their pivotal paper that describes the use of the combination. And what you can see in the upper left corner, they show the incidence of acute graft-versus-host disease, which was lower in individuals who received cyclosporin together with methotrexate compared to those individuals who received cyclosporin alone. There was no difference in the incidence of chronic GVHD, as you can show on the bottom left corner between the two groups. The other finding from this paper is that the immunosuppressive therapy was needed to prevent graft-versus-host disease, but was associated with increased risk of relapse. So they show that the combination of cyclosporin and methotrexate was not associated with an increased risk of relapse in some of the more chronic malignancies, but on the bottom right, in an acute leukemia patients, which have a very aggressive type of leukemia, the combination of the two drugs was associated with a higher risk of relapse than each of the drugs alone. To date, careful balancing of the risk of graft-versus-host disease and the risk of relapse remains really what the art of transplantation is. The next drug in the repertoire for GVHD prophylaxis is ATG, or antithymocyte globulin. The concept behind it is pretty simple. As T cells are the culprit of GVHD, the elimination of T cells through immunological mechanisms was considered an interesting concept. This is now achieved through a production of ATG, or antithymocyte globulin. So how we do that? Well, we infuse human T cells into rabbits, which leads to rapid clearance of these T cells through production of antithymocyte globulin. This is an antibody produced by the rabbit against the human T cells. We isolate this serum from the rabbits, and the serum is then infused into patients undergoing allogeneic stem cell transplantation. And this actually has twofold effect. Depletion of recipients' T cells reduces the risk of graft rejection because the immune system of the recipient is depleted. And the depletion of donors' T cells reduces the risk of graft-versus-host disease, which is when the donor's immune system affects the recipient. So I already explained HLA loci and said that they're inherited in a Mendelian fashion. This means that you receive one complete set of HLA loci from one of your parents and the other set of the loci from the other parent. Each of these sets that are passed together on a single molecule of DNA are called a haplotype. And in this picture here, I'm giving an example where there are 4 haplotypes: green, teal, red, and blue. The patient on the bottom has a green, one that's circled in the blue box, has a green and a blue haplotype. Of the 4 siblings of this patient, one who received the teal and the red haplotype has nothing in common with the patient, and these 2 individuals are incompatible. The 2 siblings that received the green and the blue haplotype is the same as the patient here, so they're identical. These are identical siblings. And then there are 2 other siblings that are considered haploidentical or half identical, and they share one of the 2 haplotypes with the patient, one sharing the green haplotype and the other one sharing the blue haplotype. So this is what's known as the haploidentical donor. These are individuals with whom you share half of your HLA loci that are housed on the same piece of DNA that you've inherited from the same parent. So how do we use that? Well, the utilization of haploidentical donor stem cell transplant was enabled by the discovery of a drug called cyclophosphamide, or post-transplant cyclophosphamide, which was able to selectively kill those T cells from the donor that recognize the recipient as foreign, while leaving alone those T cells from the donor that did not recognize the recipient as foreign. And those T cells that recognize the recipient as foreign are called alloreactive T cells, meaning they are reactive against another patient. So infusion of donor stem cells is always accompanied by infusion of certain number of T cells coming from the donor. We could theoretically eliminate them completely because we have ways of doing that, But that would not work, as we actually do need some of those T cells to ensure engraftment. And they work by fighting off the recipient's immune system to allow the graft to grow. So some of the T cells from the donor do not recognize the recipient as foreign, and they happily go around, and they're shown on the bottom. Others, however, recognize that they're someplace else, and they begin rapidly expanding, and we call this process activation of alloreactive T cells. And this usually takes about 3 to 4 days to happen. And this is exactly why at the 3-day mark, we give the drug called cyclophosphamide. What cyclophosphamide does, it's a chemotherapeutic drug, but it predominantly kills rapidly dividing cells. And because only the alloreactive T cells are the ones that are rapidly proliferating, at this point in time, the cyclophosphamide will leave those that are happily-go-lucky T cells that are not dividing and leave them alone, while at the same time, it rapidly kills up alloreactive T cells. So this is really the principle behind post-transplant cyclophosphamide and how this drug has enabled us to use haploidentical donor, which has been a revolution in the field of stem cell transplantation, because it basically provided an alternative donor for many patients that did not have a matched sibling donor and did not have an appropriate match in the database. And this is where you can use haploidentical parents as the donors. You can use haploidentical children as donors, and you can use haploidentical siblings and donors. So it really expanded our donor pool in our patient population. So I think that's enough about the sort of the timeline, the history of stem cell transplantation, and some of the sort of milestones in this field. Let's move on and talk about the principles of stem cell transplant. And how I organize this session is, or this part of the session is really, it has to do with, what is the trajectory that our patients go through from the first time they see me until we follow them up after transplant. So the rest of the talk is really going to be a pathway, a journey of a stem cell transplant candidate from the time that I see them for the first time in consultation to many years after transplant. So the first question that we always ask ourselves when we see a new patient that is referred for allogeneic stem cell transplant is whether the transplant is indicated or not. What does that mean? Well, it means, does the patient have a disease that can be cured with transplant? And the best answer to that question is to basically appreciate the relative proportion of various underlying conditions to allogeneic stem cell transplantation. And this is the data that's reported to EBMT, or European Bone Marrow Transplant Repository or database. So if you look on the left side, the pie chart on the left side, 38% of all transplants are done for acute myeloid leukemia, which is a very aggressive form of leukemia. 16% of all transplants, these are the patients shown in dark green. 16% of all transplants are done for acute lymphoblastic leukemia, which is shown in light blue. And this is another type of very aggressive blood malignancy. Another 16% of transplants are done for myelodysplastic syndrome or myeloproliferative neoplasm. These are low-grade malignancies of the bone marrow that, if left untreated, eventually do progress to high-grade leukemias. And these are shown in the 2 shades of light green. Another 12% of all patients are transplanted for various what we call lymphoproliferative disorder, defined as non-Hodgkin's lymphoma, Hodgkin's lymphoma, chronic lymphocytic leukemia. And these are just shown in different shades of blue in the picture. And then some 5% of the patients, so about 1 in 20, are transplanted for bone marrow failure syndromes, including aplastic anemia being one of the most common ones. These are the patients shown in cherry red. On the right-hand side, I'm just providing a comparison. These are patients this is the breakdown of the patients that have received autologous stem cell transplant. And autologous stem cell transplant is something very different. This is where a patient receives a transplant from their own. Majority of these patients get transplanted for what we call multiple myeloma or plasma cell disorder. That's what PCD stands for, about 52% in dark blue. And then this is followed by non-Hodgkin's and Hodgkin's lymphoma combined, which are the 2 shades of the lighter blue, about 37%. And then sort of you have a grab bag of other conditions that are shown in other colors. So the first question we answer, is the patient indicated? And this is kind of where we look at, well, is there evidence in the literature that transplant can cure these conditions? And it's likely if you have one of the conditions shown on the left-hand side in this pie chart, then you will be a stem cell transplant candidate. Now, let me clarify something. Not every patient with AML or ALL or myeloproliferative neoplasm is a candidate for transplant. We now have a very careful and thought out risk stratification systems that classify these patients into sort of low risk, medium risk, high risk, and then based on where they fall on the risk scale, they are referred for transplant or not. The next question you ask is, well, is there a suitable donor? We can't do a transplant without a suitable donor. So there are, in fact, several categories of suitable donors nowadays. So the matched related donor, and what this graph shows, pardon me, is basically how has the donor use changed over time? So from 1980s to basically 2021. So matched related donors are shown in blue line, matched unrelated donors are shown in orange line, haploidentical donors are shown in the green line, and mismatched unrelated donors are shown in purple line. So what, as I said, this slide shows is a trend in donor years over time. And I want to observe a couple of things. So matched related donors, so this is your brother and sister, who once represented the most common type of donor used, if you look at back in the 80s, are now actually in the second or third spot. So we no longer are using predominantly matched related donors. That is because we now have a growing worldwide database of donors that has now become very expanded and covers most parts of the world. And therefore, the use of matched unrelated donor has expanded the transplant, and now the matched unrelated donor shown in orange is the #1 type of donor that we use in transplant. And actually followed closely is the haploidentical donor, which is in the green line, and you can say that's been steadily growing since about 2010, and we're increasingly using haploidentical donors in transplantation. The use of mismatched unrelated donors, so these are the donors where there's a match at 9 out of 10 sites, has kind of remained steady over time, and that's the purple line, the light purple line. So I will, and I mentioned here that finding a matched unrelated donor is easy, but I actually have to give you a word of caution is that whether you have a suitable unrelated donor is, in fact, may depend on your racial background. And if you're white, your chance of finding an unrelated donor is close to 80%. If you're indigenous, the chance is in the range of 60%. If you're Latino, the chances in the order of 50%. If you're Black Canadian, then chances are much less. There's a 28% chance or 29% chance that you may find a donor in the unrelated database. And the result, this is simply a consequence of some of racial populations being really underrepresented in the international database. And part of our sort of mission nowadays is to spread the word about the database and sort of familiarize people from different ethnic groups about the database so that we may actually get better representation of different ethnic and racial groups in the international database because it'll enhance our ability to find donors for more patients. The next question we ask is the patient eligible? And I want to distinguish something here. There's one question is the patient indicated? The second question is the patient eligible? Whether a transplant is indicated or not depends on the underlying disease and whether or not the transplant represents a potential cure for the disease. Whether a patient is eligible for transplant, it really has to do with whether they're fit enough to undergo transplant. So in other words, and I want to put it very bluntly, is that this is where I ask myself, how likely is my intervention to kill this patient? So how likely is this patient to withstand what I'm planning to do to them? And basically there are many factors that go into this calculation and include age, certain performance status. LVEF stands for heart function, heart rhythm, lung function, liver function, whether they have another cancer, what's their creatinine, which is a reflection of their kidney function. Do they have any infections? How are they doing from a psychological point of view and stuff like that? So this is where you really evaluate, can this patient withstand the intensity of the therapy that I'm proposing to use? In fact, our evaluation of how likely it is that the patient will experience toxicity and mortality is not just left up to our gut feeling. We now have very formalized ways of evaluating this. And one of the most common methods involves the use of what we call HCTCI, which is a formalized system for numerical representation of patients' comorbidities. HCTCI includes conditions that are included here. So arrhythmia, cardiac problems, inflammatory bowel disease, I'm not going to read them off. And patients with a low HCTCI score are likely to tolerate transplant better than those with a high HCTCI score. And then conversely, patients with a high HCTCI score are much more likely to die from transplant than those that have a lower score. And I want to illustrate this to you and show you how well HCTCI predicts outcomes. So on the left, we show incidence, or the rate, if you wish, of complications causing death post-transplant. And on the right, you have overall survival post-transplants, and both are shown over a 5 period of time. So the green line represents individuals with an HCTCI score of 0, meaning they have no comorbidities. Blue line are individuals with an HCT score of 1 to 2, meaning they have 1 or 2 comorbidities. And then the yellow line represents the individuals with an HCTC score of 3 or above. So these are patients with multiple problems. So you will appreciate that mortality from complications at 5 years, it more than doubles from 20% to 50% as the HCTCI score increases from 0 to 3. And the survival at 5 years falls from about 70% to less than 30% as we increase the HCTCI score from 0 to 3. So it's therefore critical to carefully evaluate each patient's comorbidities and appreciate how they may affect their eligibility for transplant. So now we've said the patient's eligible, the patient's indicated. So what are the steps? So assuming there are multiple donors available, the next step is to select the most suitable donor. This is a very, very crude and very simplified algorithm we follow at Princess Margaret Cancer Center in Toronto. This algorithm, by no means that this is unique, this is unique and does not apply to every center in the world. But at our center, we will select a matched related donor over a matched unrelated donor. And we will then next pick in line a 9 out of 10 unrelated donor that has a mismatch at DRB1 or DQB1 or C mismatch. So one of those 3 mismatches. If we have a haploidentical donor and a 9 out of 10 donor with these particular mismatches, they're approximately equally good donors. And the least good donors, I would say, are those that are 9 out of 10 mismatches with an A or a B mismatch. We also consider other factors, donor and recipient CMV status, serostatus, blood group, gender, weight discrepancy. We like to get bigger donors because they give more stem cells. And there's also some logistical considerations. So flying stem cells from parts of Canada or US takes 2 to 3 hours, 3 to 4 hours. Flying from Europe takes 7 to 8 hours. Flying from the Middle East is 12 hours. Flying from Australia is like 24 hours or above. So we take that into account. We try not to get donors from halfway across the world because the stem cells do not like to be transported on airplanes for 24 hours. The viability of these stem cells decreases significantly with time. So the next step is really picking the conditioning regimen. Conditioning regimen is the preparatory regimen given to stem cell transplant recipients ahead of the infusion of stem cells. The role of the conditioning regimen is to eradicate the malignancy and make room for the donor stem cells. Conditioning regimens are typically divided into what we call MAC, myeloablative regimens. They're able to fully destroy recipient stem cells, and the recipient needs stem cell rescue to survive. Non-myeloablative, these regimens are very mild, and the stem cell rescue would not be necessary. And then reduced intensity conditioning is in between. These regimens do not belong to either of the 2 groups. Typically, a myeloablative conditioning is defined based on the dose of busulfane, which is a commonly used drug in conditioning, or the total radiation dose that we use. On the right, you can actually see the relationship between conditioning intensity, level of bone marrow ablation, and the intensity of cytopenias, or how low the counts get. The field has now moved recently away from this binary view of the world where you look at regimens as MAC versus RIC to a more fluid view of conditioning intensity. So each of the drugs is kind of awarded a point based on its own intensity, and the system allows different scores to be assigned for different doses of the same drug. And the total intensity score, or the total conditioning intensity is calculated by adding the scores of each of the individual components, and the sum is called TCI, or total conditioning intensity. And the system allows for a more fine-tuned view of conditioning intensity. For example, a toposide TBI and FP4, these are 2 different myeloablative regimens that are considered myeloablative. So, based on that bicentric view of the world, they're equal intensity, but they're actually not equal intensity. The etoposide TBI is considered a slightly more intense regimen. And when you use these more fine-tuned ways of comparing intensity, it allows you to gradually sort of understand or appreciate regimens in the order of their intensity. So you can see how we've ranked them here based on their intensity. And you have myeloablative regimens that are not the same strength as each other. And you have RIC regimens that are, all RIC, but are slightly different from one to the other. So we're now moving to a view of the world or the transplant world where the conditioning is more of a spectrum rather than yes or no. So this is basically how different conditioning regimens affect different transplant outcomes. Myeloablative conditioning causes highest degree of tissue damage, which is thought to be a precipitant for graft-versus-host disease, and therefore you have the highest risk of GVHD with MAC. The risk of GVHD decreases with the increasing intensity and is lower with RIC and even lower with non-myeloablative regimen. The risk of non-relapse or mortality or transplant-related mortality mimics the risk of GVHD, and it's highest with MAC and the lower with RIC and the lowest with NMA. On the contrary, the more intensity you use, the lower the risk of relapse in the case of leukemias, and vice versa. And therefore, the risk of relapse is lowest with MAC, but highest with non-myeloablative conditioning. The risk of relapse and the risk of NRM typically, or non-relapse mortality, they typically balance each other out so that in the end, head-to-head comparisons by different conditioning intensities, they show very similar outcomes overall. This is important because when we consider many factors when we choose the conditioning. So non-myeloablative conditioning, something that we would use in a patient who does not have a cancer, because you don't really need, there's nothing there that you need to kill. So for example, aplastic anemia patients will get non-myeloablative conditioning. Myeloablative conditioning will be used with patients who have a malignancy, cancer, and are young and fit. And then reduced intensity conditioning will be used in individuals who have malignancy or cancer, but are less fit. And then the final step involves the selection of the most appropriate GVHD prophylaxis. And I cannot stress enough here how much variation there is center to center. So this is the algorithm followed at Princess Margaret Hospital and varies across the world. So in the matched related setting, we use a combination of post-transplant cyclophosphamide, cyclosporin, and another drug that I didn't get a chance to talk about called mycophenolate mofetil or Cellcept. In the unrelated setting, we use ATG or antithymocyte globulin with the combination of PTCY and cyclosporin. And in the haploidentical setting, we use PTCY, cyclosporin, and ATG, but at a higher dose of ATG. Now, PTCY or post-transplant cyclophosphamide is cardiotoxic to the heart. So we have other regimens that we can pick from in individuals that have a heart dysfunction going into transplant, and they're listed on the slide. But again, this is very center-specific and not something that I would ever go to another part of the world and tell people this is how you have to do things. It really depends on many other factors. One of the most challenging parts of our interaction with potential transplant patients is understanding the prognostication we provide at the time of consult. And I'll just spend a couple of minutes trying to clarify what the numbers mean, the numbers that we give to the patients. So in transplant, we traditionally quote outcomes at the 2-year mark. And the reason is because things usually stabilize at 2 years after transplant, and most of the events would have happened already. So if you look at the 3 curves, the one on the left, middle, and the right, they kind of flatten out at some point in time. So that's why we quote things at 2 years. We don't quote things at 3, 4, 5, and 10 years because patients are not followed for that long. But most of the patients that are alive and well at 2 years will continue to be alive and well at 3, 4, 5, and 10 years. On the left is what we call the typical Kaplan-Meier survivor curve. The patients below the curve are the ones that are still surviving, while the patients that fell off the curve are the ones that died. They're on the top part of the curve. So in this example, the 2-year-old survival is around 50 to 60%, meaning that 50 to 60% of patients are alive, while 40 to 50% have died. So if a patient has reached the 2-year mark, if you notice, the curve flattens out and they're likely to continue being alive for the time coming. Patients who have died after transplant are typically divided into 2 categories: the ones that have died of relapse or the ones that have died of non-relapse mortality, which is defined as any complication from transplant that leads to death other than relapse. So in this example, the 2-year relapse mortality is about 30 to 40%, and the 2-year non-relapse mortality is around 10%. And you will find that that the 3 numbers add up to 100. So if you take 100 and you remove the patients that died of relapse and you remove the patients that died of non-relapse mortality, you'll be left with a proportion of patients surviving. So this is often something that patients don't understand when we quote these numbers. So I thought it would be useful to include these curves and sort of specify exactly what they mean. So we have so far approached stem cell transplant as a puzzle, discussing each piece separately. So how does it look when we put it all together? So patients are typically admitted to the hospital about 6 to 7 days before stem cell infusion. For the first several days, patients received some form of conditioning, either chemotherapy or radiation. The conditioning therapy is closely related to the GVHD prophylaxis, and patients usually get a GVHD prophylaxis around the same time. ATG usually before transplant, post-transplant cyclophosphamide after transplant, and then cyclosporin, methotrexate, and MMF usually after the stem cells are infused. The day of the stem cell infusion is called day 0. Engraftment, which is the term used to describe the situation where the new stem cells start to work and they start to produce enough blood cells, usually happens around day 14. The first 30 days post-transplant are the most critical in terms of complications such as toxicity and graft-versus-host disease. And then patients are usually discharged home around 30 days post-transplant. So this is the trajectory that most patients will see when they're admitted to the hospital for transplant. So what happens after transplant? Let's talk about some complications after transplant. I like to approach these complications in a systematic fashion and divide them into categories based on the underlying cause. These can include complications related to conditioning therapy, complications related to infection, graft-versus-host disease, graft failure, and disease relapse. And I'll just touch upon each of these for basically a minute per complication. Endothelium is a term used to describe cellular layer that comprises the lining of all of our blood vessels as they travel between organs and within organs. And endothelial damage is probably the most common mechanism by which chemotherapy and radiation cause toxicity after transplant. And there's a number of syndromes that we see in patients after transplant that are products of this endothelial damage. Veno-occlusive disease, which is characterized by weight gain, accumulation of fluid in the abdomen, kidney failure and liver failure is caused by endothelial damage to the liver system. Engraftment and GVHD syndromes that are characterized by inflammation, leading to tissue damage and multi-organ dysfunction is also endothelial damage. Thrombotic microangiopathy, TMA, and PRESS syndromes are characterized by blood, neurological, and kidney abnormalities. These are also caused by endothelial damage. And then several other disorders characterized by increased bleeding, called diffuse fused alveolar hemorrhage and capillary leak syndrome, are also caused by endothelial damage. That's why the chemotherapeutic agents that we use, we well understand their toxicities and try to warn patients ahead of time about what some of the dangerous side effects they may experience. Infection represents the most common complication for transplant. They're divided into 3 phases. Infections that happen during the pre-engraftment phase are typically caused by neutropenia, meaning no neutrophils, and barrier breakdown, meaning breakdown to the gut from the chemotherapy. And they include predominantly bacteria and herpetic virus infections, but they can also be fungal infections. Infections that happen during the immediate post-engraftment phase are thought to arise due to the defect in the cellular and antibody immunity. They can include bacterial infections, but a little bit less so. More common viral infections with CMV, HHV6 virus, EBV, as well as fungal infections. And then we have infections that take place at very late transplant phases that arise due to defects in humoral immunity and include, varicella zoster, also known as zoster, shingles, PJP pneumonia, and so on. Graft failure. Graft failure is a situation where the grafted stem cells do not survive and are unable to reestablish basically growth of blood. Graft failure is divided into primary and secondary based on whether you've engrafted and then lost it or you never engrafted in the first place. The mechanism of graft failure is complex. It's represented here in a very sort of simplified fashion. The stem cells are referred to as the seed and the bone marrow of the recipient as the soil. So graft failure is often the function of the insufficient number and quality, number and quality of the stem cells infused. So you have to put in enough to prevent graft failure. In some cases, it is the function of the unsupportive soil. So that's where the remaining elements of the recipient's immune system are just not happy with the stem cells and they attack them as they go in. And then finally, various other processes that are shown here as insects, such as infection, immunity, graft-versus-host disease, they exert a negative effect on the graft. So we're usually try to get rid of these processes in order to stimulate healthy growth of transplanted stem cells. Before I specifically look at GVHD, let's do a very quick brief review of the contribution of the described complications to mortality of transplant patients. So here I have shown you the breakdown of the cause of death by different type of donor, related, unrelated, and haploidentical donor, before 100 days and after 100 days after transplant. So I just want to highlight a couple of things. Organ failure represents the most common cause of death at less than 100 days in all types of transplant, attesting to the high degree of toxicity of the used therapies. The primary disease represents the most common cause of death long-term, suggesting that a significant proportion of patients are still unable to achieve cure with transplant. And then the risk of death from infections is lowest in related donor recipients and highest in haplo and unrelated donor recipients, basically reflecting the higher use of immunosuppressive therapies in this patient population. One complication of transplant that deserves its own spot is graft-versus-host disease. It represents an attack that's orchestrated by the immune system of the donor against the tissues and organs of the recipient. GVHD was usually in the past classified as acute GVHD that occurred less than 100 days after transplant, and chronic GVHD happening after 100 days after transplant. But it's increasingly recognized that it's not just the timing, but the constellation of symptoms that characterizes GVHD as acute and chronic. And now we have what we call the classic acute GVHD, classic chronic GVHD. We now have an overlap syndrome that can happen around 100 days that sometimes has features of both. If you wanted to know all about acute GVHD in one slide, this is it. It involves usually three organs: skin, gastrointestinal system, and liver. In the skin, the most common symptom is diffuse itchy rash that resembles sunburn a lot. And on biopsy, when you see is the skin infiltrating with lymphocytes. In the GI tract, the most common symptoms is nausea, vomiting, and diarrhea. It can be wicked. You can have 20 to 30 bowel movements per day. And on pathology, we often see sort of dying cells in the wall of the gut, loss of the little crypts in the wall of the gut. And in the liver, the most common presentation is jaundice or yellow skin. And what we see is loss of the bile ducts when we do a liver biopsy. I'm not going to spend too much time on here, but acute GVHD is staged and graded based on severity from grade 1 to 4, depending on how many organs are involved and how badly they're involved. And this is really beyond the sort of level of this talk, and I'm not going to spend any more time on that. There are many strategies for the treatment of acute GVHD. They're also beyond the scope of the talk. This slide provides a general summary and classification. So steroids, they represent the mainstay of treatment. They can be systemic, oral or intravenous, topical for creams for the skin, and what we call oral non-absorbable steroids, like a drug called budesonide, which you take and it works in the gut but doesn't get absorbed from the gut. Calcineurin inhibitors, or CNI, these are drugs like cyclosporin that I mentioned already. There's another drug that's a cousin of cyclosporin called tacrolimus. And these drugs are actually both used in prophylaxis or prevention of GVHD and in the treatment of GVHD. We also have supportive drugs such as ursodiol, which are used in special instances to treat patients with liver GVHD. There's other treatment strategies that involve phototherapy or ECP. And despite many therapies, about 30% of the patients are called steroid refractory, meaning that they do not respond to this treatment and need second-line agents such as Jakavi or ruxolitinib, which is a fairly novel drug that has shown promise in treatment of GVHD in patients that do not respond to the initial therapy. Different from acute GVHD is a chronic GVHD, which is a very different syndrome that develops much more slowly, insidiously, and over a longer period of time. Acute GVHD is primarily a T-cell-driven process. In chronic GVHD, we much more have an important role of antibodies, of B cells and antibodies. And they affect many, many different organs. Eyes that can be very dry. This is called a Sika syndrome. Mouth, dry mouth, which is part of the same Sika syndrome. Strictures in the esophagus that make it impossible for the food to pass by. This causes nausea and vomiting. Pancreatic insufficiency, causing chronic diarrhea. Skin changes that cause tightening of the skin that's similar to the condition called scleroderma. Muscle and bone abnormalities where you get joint stiffness and contractures, and lungs, particularly a very scary sort of constellation of symptoms called bronchiolitis obliterans, where you become increasingly short of breath, and may need supplemental oxygen, which may actually lead to enough lung damage that can cause severe mortality and morbidity in our patients. Similarly to acute GVHD, there are many treatment strategies that can be used in chronic GVHD. The steroids and calcineurin inhibitors, meaning cyclosporin and tacrolimus, represent the frontline therapy in chronic GVHD as well, just like they do in acute GVHD. And then from then on, the situation is quite different. There's a multitude of second and third line agents, including MMF, ruxolitinib, which is Jakavi, which we talked about, ECP, imatinib, ibrutinib, hydroxychloroquine, azathioprine, or Imuran. There's really just a number of agents. But I can't really have this talk without basically highlighting a new kid on the block called Rezurock, called belmosadil, which works through the inhibition of a protein called ROCK2 signaling, and it decreases cytokine production and proliferation of pro-inflammatory cells, and increases proliferating Treg cells, which promote immune tolerance. And it is through the signaling that belmosadil or Rezurock has been shown to be able to reduce both inflammation and lead to reversal of some of the negative remodeling that's characteristics of chronic GVHD. And, putting it all together, you may now start to realize that, getting a stem cell transplant is tough. Getting through transplant is very tough. Surviving transplant is very tough. But surviving transplant is not the end of the road. BMT survivors continue to experience a myriad of long-term health issues, which require ongoing care by a very experienced and specialized team of doctors that understand the field of allotransplantation. So these patients often have increased risk of secondary malignancies and require careful screening for secondary cancers, increased risk of cardiovascular disease. I typically tell my patients that transplant will age them by at least 10 years. Increased risk of liver dysfunction, gonadal dysfunction, infertility, premature ovarian failure, and early menopause in our female patients, endocrine diseases, osteoporosis or low bone density, iron overload, chronic kidney disease, pulmonary disease, and obviously neuropsychiatric conditions, including anxiety and depression, are much prevalent in our patient population. So to wrap up, I wanted to summarize the session. Basically, allogeneic stem cell transplant is a high-intensity therapy which involves replacement of recipient's hematopoietic stem cell system with that of a donor. Allogeneic stem cell transplant represents the only known cure for several blood cancers and several bone marrow disorders, such as aplastic anemia. Allogeneic stem cell transplant requires the use of conditioning therapy and prophylaxis or prevention against graft-versus-host disease. Careful evaluation of the recipient is required before allogeneic stem cell transplant to ensure that the patient is fit enough for the procedure. Most common complications are due to treatment-related toxicity, infection, graft-versus-host disease, graft failure, and disease relapse. And then recipients of allogeneic stem cell transplant often suffer from chronic and long-term health issues that require ongoing follow-up and care. And with that, I'm going to close and thank you so much for your attention today.
Wow, thank you so much, Dr. Pasic. Lots of information there. If anybody has a question, you can either raise your hand or use the Q&A to type your question. If you raise your hand, I can just unmute you and you can ask the question. Maybe while we're giving people time on that, I'll just ask, is the number of these transplants happening in Canada going up every year or decreasing?
So if you look at, and not just Canada, we report to the organization called CIBMTR, which is Center for International Bone Marrow Transplant Research. The number of transplants is going up over time, despite sort of the use of, novel therapies and so on. I think particularly because of our recognition that, some of these conditions do warrant a transplant, that they can only be cured with a transplant. Also, through the expansion of the bone marrow transplant database or the donor database, more patients actually have an eligible donor. The expansion to donor use to include haploidentical donors, and also our ability to offer transplants with more safety and fewer complications has sort of increased the population that is eligible for transplant. So the number has been going up over time.
And about how many does your center do a year?
So this past year, 2023, we just broke our record. We did over 200 transplants. So 206, I believe, was the final number. And if you count, about 200 working days, 220 working days in a year, or 250, we're basically doing one transplant for every working day of the year.
Wow. Oh, we have a comment. Just thank you very much. Any other questions out there? Okay, well, I don't see any. So again, I just want to thank you, Dr. Pasic, for presenting today. And as I said, this webinar is recorded, so I'm sure we'll get some views of it online as well. And for the rest of you on the call, just a reminder to check our website for news of upcoming meetings and for information on how to register for those. And we'll soon be publishing our winter newsletter. So if you don't already receive that, you can sign up for that on our website as well. So thanks everyone for attending and enjoy the rest of your evening.
Thank you.
Thank you.